I have to introduce the speaker today. Our lecture is Osteoarthritis in GP Practice by Dr. Chathurika Dandeniya. She graduated from University of Peradeniya in 2019 with the record. She had received distinctions in all three undergraduate subjects. After that, she did MD in Colombo 2016 and later MRCP in UK in 2017 and in MRCP Rheumatology October 2020. At present, she is working as a consultant rheumatologist and rheumatology and rehabilitation at Department of Medicine, Faculty of Medicine, University of Peradeniya. I invite Dr. Chathurika Dandeniya to conduct our lecture today.
Okay, thank you very much for inviting me and for this occasion. And I chose to speak about osteoarthritis for the talk today because it's such a common problem in clinical practice, day-to-day practice, whichever the clinical setting, whether you are doing a medical clinic, whether you are seeing patients in the OPD or a rheumatology clinic. It's such a common clinical problem, and for us also it's important. Most of us in the audience here, you would experience knee pains from time to time. So osteoarthritis is not uncommon at all. So because we all age, this is part of aging. So to move on, so what I will be speaking on today, can we go to the previous slide please, is about, to start off with, I will explain a bit about what is osteoarthritis, but I will not go into a lot of pathophysiological details because there's a lot of controversy regarding here, and it's not really going to help you in the practice anyway. And the pattern of osteoarthritis seen in our setting, in our community, and how to manage, and more importantly, how not to manage, but not to do. And also, a very important point, knee pain is not always osteoarthritis because we tend to miss a lot of things just by assuming, okay, knee pain, female, elderly, it's going to be osteoarthritis. It's not. And I will be summarizing the key points at the end. So, moving on. So, what is osteoarthritis? So, traditionally, we have looked at osteoarthritis as a wear and tear. Like, it's the part of aging, so there is damage, there is wear and tear. So, cartilage damage, that's how we explain it to the patients as well. So, but there is now emerging evidence to say there is a significant inflammatory component as well. So, about this inflammatory component, whether that is the inciting thing, or like whether the inflammation started first or whether the damage started first. It's a very difficult question to answer. It's like chicken or the egg, which one came first? Nobody knows. That is the honest answer that I can give you at the moment. But like there is interest because the new therapies, the newer therapies, the targeted therapies for osteoarthritis are being aimed at like trying to target at molecular level, trying to stop the inflammation. Can we modify the disease? But so far the results haven't been very promising. So we'll come to that when we come to the management. So far what we have learned is, whatever happens, at the end of the day, advanced osteoarthritis is irreversible. Because cartilage is a tissue which is inherently cannot regenerate. Once it is damaged fully, it can't regenerate. So it's beyond our control. Our bodies are designed in such a way. Now, we know when we have a stroke, we do recover. But how do we recover? It's because of the elasticity or the plasticity of the brain. It's because the rest of the brain will take over the function of what was damaged. It's not because the dead brain tissue is coming back to life. We know that it's not going to happen because neural tissue is designed in such a way that it cannot regenerate. So cartilage is no better. It's the same. There is no way that it can regenerate. Whatever the therapies are directed at the rest of the thing. So as I said, it is predominantly degenerative. However, there is a lot of talk about the inflammatory component. And as I said, it starts off probably as the damage because whatever said and done, like you have seen, we have all seen patients who have post-traumatic osteoarthritis, those who had like injury to the knee which triggered the inflammatory response probably later on. So for there to be an inflammation, there has to be a damage in the first place because we know inflammation is body's response trying to repair damage. So it's only logical that damage starts first. So damage starts and then the inflammation tries to repair that. But the problem here is the inflammation is maladaptive. It's trying to repair, but what is happening is actually putting things more in danger. So due to a lot of things which I'm not going to go in detail, but there is a complex relationship with obesity, because we think that obesity is only because of the mechanical loading. If somebody is obese, like when they walk, the body will be like bearing more weight. And when you explain to patients about weight reduction also, an easy way to tell them is, okay, what is your height? What is your weight? And when the patient says, okay, I'm about 5 feet tall and I weigh about 80 kilos, you can just explain to them, okay, if you're 5 feet tall, your knees have been designed to bear only about 50 kilos of weight. And instead you are 80, so your knees are bearing 30 kilos more than what it is supposed to be bearing. When you put it in that way, they tend to understand, okay, what is this relationship between weight and the weight bearing and the knee pain. And also the more important thing is when you walk, so this is only when we are standing that the knees are bearing 30 kilos more than what they should be. If you are walking, your knees will be bearing twice the amount of your body weight. So that is how our joints are designed. Your knee will be bearing twice the amount of body weight, your ankles will be bearing 4 times the body weight. Which means if you go up in the weight more than what you are supposed to be by 10 kilos, your knees will be bearing the forces of 20 kilos when you are walking. If you are running, that is going to be 40 kilos. If you are walking, like it's 2 times. If you are running, it's 4 times. So, and the opposite also true. Now, when you say that the patients are okay, they are very depressed because they know the weight is not going to come down. And like the next thing you can say is, okay, it also means if you lose 2 kilos, your knee is going to think that it lost 4 kilos. Then that is a bit of a positive reinforcement. So we'll come and talk about this management, weight reduction and the evidence for that when we come to the management. So the important thing, okay, when a patient comes to you with knee pain, so I keep on talking about knee, I will tell you later why, because in the community, in our patients, osteoarthritis, although it can happen in any synovial joint, where we see the most commonly is the knee. It is the knee. So technically it can happen at any joint. So we see shoulder joint osteoarthritis, elbow joint, and sometimes hip, and also the hand osteoarthritis. But what we see more commonly is the knee. So that's why I keep on talking about knee osteoarthritis. So when the patient presents you with knee pain, or rather any joint pain, how do you know whether it is a mechanical pain or an inflammatory pain? Because when we come to a diagnosis, that is the most important part. Because I tell this always to the students, listen to your patients and the patient will tell you the diagnosis. You don't need a lot of sophisticated investigations, particularly in rheumatology. Or the good, that because we don't have investigations anyway, and if you have a good set of ears and a good set of hands, you don't need many investigations anyway. So listen to the patient, because differentiating between mechanical versus inflammatory joint pains is all through the history. So ask the patients about early morning stiffness, early morning worsening of pain, early morning stiffness, what happens? Because like we have all had participated in sports meets at one time or the other, sometimes under duress, but we have all participated. So you have all run the mile and have realized that when you are unprepared and when you run, you get a lot of joint pains. So what did we do to recover from the pains that we got after running? We would rest. That's only natural. So if we get a joint pain after a mechanical trauma, after a mechanical insult, what we do is we rest. And by the next day, most of the time we are like, okay, if you take some paracetamol and you go to rest, by the next day you are okay. We are back at lectures after the faculty meet. So that is how it happens. However, if a patient has an inflammatory pain, they would rather work rather than rest, because they know if they stop, it's difficult to get going after that, because that is the stiffness. So it's not really accurate to say it's early morning stiffness. Rather than it's early morning stiffness, it is inactivity stiffness. We talk about early morning because not like the doctors and the nurses, the normal population go to sleep at night and they wake up in the morning. The abnormal population like us might work in the night also. So a doctor who only does night shifts come to you and you ask about early morning stiffness? No early morning stiffness, because in the early morning, like it's after a night shift, they have been working through the night, so no early morning stiffness. So it's rather the inactivity stiffness that they have. So they rest for anything longer than like 1 hour. it's difficult to get going again. So those who have inflammatory joint pains would rather work. So housewives who have rheumatoid arthritis will come and tell you, like after I start working in the kitchen, like after I have done the day morning bits, I'm okay. So that should alert you. That's not mechanical pain. That's an inflammatory pain. So where do we draw the line to say whether an early morning stiffness is significant or not? That is at 30 minutes. So why do we draw the line at 30 minutes? Not because of some divine being having told us, okay, draw the line at 30 minutes. So it's not because of that, it's not written in the Bible or something, that 30 minutes you have to say that's an inflammatory pain. No, because it comes from research evidence. To say it's like your normal blood pressure. So how do we know 180 by 120 by 80 is the normal blood pressure? So it's not written in rock, because if that was the case, I should be admitted to a hospital because my normal blood pressure is always 90 by 60. Doesn't mean I'm hypotensive. And there may be like bigger made people here who are like whose normal blood pressure is about 130/90. Doesn't mean that it's wrong. We go by 120/80 because it's a Gaussian distribution, and we look at the mean, median, mode, which all fall in the middle. So we look at the middle 50%, in other words. Okay, so this joint pains, the duration of early morning stiffness is also something like that. So what the studies have looked at is, okay, at which point if we set the cutoff limit, can we accurately identify those who have an inflammatory arthritis versus those who have a degenerative joint disease? And they decided, okay, if we draw the line at 30%, that has 30 minutes, that has enough sensitivity, enough specificity, so that we will not overdiagnose, we will not miss patients with an inflammatory arthritis. So if a patient has early morning stiffness for 60 minutes, that is even more specific than a 30-minute early morning stiffness to have an inflammatory arthritis. That doesn't tell you if the early morning stiffness is only 20 minutes. No, you go back and come back to me when the morning stiffness is 30 minutes, because that's what my teacher told me. It has to be 30 minutes. You don't do that. You interpret everything in the context to see, okay, even though the early morning stiffness is only about 20 minutes, it doesn't really last for half an hour, but still there may be other characteristics to tell you, okay, this may be inflammatory. So likewise, you have to interpret everything in the context. So the bottom line is, the most important part when a patient comes to you with a joint pain is to establish, is this a mechanical joint pain? Is this an inflammatory joint pain? If a patient feels better walking on an inflamed leg, that is not mechanical. If a swollen knee joint and the patient says, I'm okay as long as I'm walking, that's not osteoarthritis. Okay? Right. So moving on. So I told you, I keep on talking about the knee because in our community, knee osteoarthritis is the commonest. So this is in contrast to the Western populations, where if you take in the US, in the UK, the commonest osteoarthritis is actually the hand and the hip. Whereas in our population, how many hip osteoarthritis do you see? It's to the point that if I see a patient with hip osteoarthritis in the clinic, I always look for secondary causes. Is this secondary to some other arthritis or secondary to a trauma or something like that? Because it's very uncommon to have primary osteoarthritis of the hip in our population. So why this is, we don't know. It may be probably something genetic or behavioral or a complex interaction, we don't know. But in our population, you all have experience. It's knee osteoarthritis, that is the commonest. And this is a photo of a hand OA you would have seen, right? The distal interphalangeal joints are very much swollen, very bony, nodular hands, very deformed, but compared to the deformity, they don't have a lot of symptoms. So the pain is minimum, but a lot of deformity. So this is hand osteoarthritis. So clinical features of knee osteoarthritis. So the mechanical pain, as I told you, that is the first thing to establish. Is the pain mechanical? That is the pain worse towards the end of the day? Yes, if they climb upstairs, downstairs, is the pain getting worse? So if that is the case, that is a mechanical knee pain. Swelling may or may not be there. Swelling is based on, it depends on whether the patient has an effusion or not. So if there is an effusion, there may be swelling. If there is not, there may not be any swelling. And the symptoms are generally bilateral, unless this is secondary to a trauma or something like that, because your whole body ages at the same rate. generally. So usually the symptoms are bilateral. So this is the red flag. If somebody comes and tells you of a unilateral joint pain, be cautious in diagnosing osteoarthritis. It may not be. It may be asymmetrical. The patient may have bilateral knee pain but right more than left. That is possible. However, usually they have some degree of symptoms in both sides. Okay? And chronic pain with intermittent flares. You all have seen that. So they will come and tell you, okay, I had pain for about the last 2 years, like low degree of pain was there, but for the last 1 week I'm unable to walk because the pain is so much and there's swelling also. So we call that an osteoarthritis pain flare. So pain flare, just like you would get in an inflammatory arthritis, from time to time flares can happen. So locking near falls in advanced disease, particularly in advanced disease. So you would have heard patients saying this, like suddenly the knee will lock and they have a tendency to fall. This happens. So this can happen due to a few reasons. One thing is if they have what is called loose bodies inside the joint. So these are, it's like your knee is like a hinge. Knee is a hinge joint. So so imagine like you have a grain of sand being caught within the hinge. So it's difficult to now open and close the door. So the loose bodies are some things like that. So these are actually calcified, detached parts of cartilage that are there lying around in the knee joint. And as long as like it moves about without getting caught in this hinge, things are fine. But while you're walking, suddenly it gets caught in the hinge and the knee locks. They can't move beyond that and they have a near fall. Okay, that can happen. And another reason why this can happen is if there is a sort of a loose part of cartilage that has broken off and it's like a hook, like it's hanging there. And again, when you're walking, suddenly it gets caught in between the two, just like that would happen with a loose body, and then the patient has a near fall. That is one. And the other reason why they can have near fall with advanced disease is because of quadriceps wasting. Because if you remember the anatomy of the patella is a sesamoid bone. So it's like a fragment of bone that is like lying about. It's actually lying within the quadriceps tendon. So the quadriceps tendon, the big thigh muscle, it goes and attaches to the tibial tubercle just below the knee joint. So just before the attachment, it has produced a bone that is lying within the tendon. So that is your patella. So patella is very important in the knee joint stability. So when we are talking about the knee, we forget about the patella. We think about the knee, okay, it's the articulation between the femur and the tibia. No, there's somebody else. So knee is, that's why we talk about 3 compartments in the knee joint. You have the medial tibiofemoral, you have the lateral tibiofemoral, as well as you have the patellofemoral, because patella is part and parcel of the knee joint. Okay? So this patella is held tight at where it should be by the patella tendon, by the quadriceps tendon. So if the quadriceps is weak, it cannot hold the patella in the correct place. So when the patients walk, they tend to sublux the patella, usually to the lateral side, because vastus medialis, the medial head of the quadriceps, is the commonest to get wasted. If you are immobilizing the knee, it wastes very easily. So because of how the forces are working, when they walk, lateral subluxation of the patella is pretty common, commoner than you think. So this is one of the reasons why they say when walking, suddenly the kneecap tends to go to one side and I tend to fall. Okay, so these are all symptoms. Then on examination, when you examine, there may be crepitus, effusion and quadriceps wasting, particularly with advanced disease. So crepitus, you all know, when you bend and like extend the knee, goes cross, and the patient says, I will put a sardina. So that's the crepitus, that's how they describe that. So the next question, should you X-ray? Should you not X-ray? A very interesting question, I would say. So whether to X-ray or not depends on what are you suspecting. In my opinion, most of the knee pains do not need an X-ray. It has a placebo effect because the patients think of therapeutic X-rays. X-ray like I asked them, okay, what do you expect by doing the X-ray? The knee pain is going to go away by the next day. No, just don't do just X-rays because the patients are asking, because it's all public money. It's a waste, because most of the time X-ray is not going to add anything to your clinical diagnosis. So, and the other thing is, until in the advanced stages, X-ray will show no changes. This has been very clearly shown, like early osteoarthritis, the changes are like the studies that have been done on early osteoarthritis, the imaging that they have used is MRI. Because the cartilage, you can't see the changes on X-ray. You only see once it starts attacking the bone that is underlying, the cartilage. Then only all these signs on the X-ray will appear. So X-ray actually detects pretty advanced disease, which you don't need an X-ray to diagnose anyway. Because again, history examination, you have the diagnosis of osteoarthritis. So particularly in our low resource settings, we really need to rethink, should we really do an X-ray? And will it change the management? Even if you do an X-ray, what is it going to change? And can it help the diagnosis? Now there it's important because sometimes we have like patients masquerading as knee pains, but not really due to problems in the knee joint. It may be an osteosarcoma of the lower end of the tibia, of the femur, that is causing this, or the upper end of the tibia, that's one. And another reason, there may be osteochondral cysts that are happening due to some reason. So, or sometimes even secondary deposits. So if you have any reason to suspect, this may be something sinister other than a knee pain. And another very important thing, I had one patient who was coming with, like he had gone all over the country complaining of bilateral knee pain. So diagnosed as osteoarthritis of the knees. Because the X-rays showed some early OA changes. But like I was observing the way that he was walking into the clinic, he could hardly walk. So the X-rays cannot explain the degree of like difficulty that he was having in the walking. So I asked him to get on the bed, and there was like certain changes that I observed when he was walking. I asked him to get on the bed and examine the hip joints. Hips were almost completely fixed. Like the rotation range of motion was limited in all directions in the both hips. So I sent them then and there to go and get an X-ray of the hips done and come back only to see it's advanced hip osteoarthritis. But he has no pain at all in the hip. He only has knee pain. This we see particularly in children also. When they have problems in the hip joint, JIA and all, when they have problems in the hip joint, they come and tell you, I have knee pain. You examine the knee, there's nothing in the knee. Examine the hip properly and you will come to the diagnosis. So in such cases, yes, X-ray is helpful. So if the patient keeps on coming, no matter what you do, they keep on coming. So you need to rethink the diagnosis, then yes, go ahead and do the X-ray. But in the majority of times, the bottom line is, try not to X-ray unless your clinical differential has sinister pathologies. And the worst thing is, sometimes X-ray can direct you away from the real diagnosis. This I have seen time and time again, where the diagnosis is actually inflammatory arthritis. But when you do the X-ray, X-ray shows OA changes. X-ray shows osteophytes OA changes, and the radiologist will also report as osteoarthritis, because like inflammatory arthritis, for changes to happen on the X-ray, it takes a long time for you to develop periarticular osteopenia, erosions and everything. It takes a long time. And the whole goal of our management is to treat before the X-ray changes appear. Because once the X-ray changes appear, those erosions are there, irreversible joint damage. So, but the thing is, when the patient complains of knee pain, you do an X-ray, X-ray shows OA changes, you automatically diagnose this as osteoarthritis without really listening to the patient. So this happens very commonly. So another reason why you should not X-ray in the first place. Right, so the most important part of the talk today, because how to diagnose when they present, you all know, you have all seen these kind of patients. So the more important question is, how do we manage? So should we aim for a cure or should we aim for a symptom relief? Most of the cases of osteoarthritis, a cure is impossible. I told you why, because like knee, whether it is knee or wherever, the cartilage is, it's not going to grow back. So you can't really cure. So what does the evidence say? When it comes to the symptom relief or for the long-term management, what do we have evidence for? So, in the knee OA, exercise. This is the number one evidence. So, and what patients come and ask you also, should I be exercising? Because the exercise worsens my knee pain. So what should you say? You need to know. What should you say? So what I generally say is, it's actually good for you to keep on walking on level ground. No hills, no slopes, which is extremely difficult in Kandy, I know. So just tell them to go to a walking track and walk. So in the Peradeniya region, I tell them to go to the university grounds. There is a nice walking track. Just walk on the walking track, because it is important that they go on level ground. So slopes they can do, After a lot of rehabilitation, after a lot of physiotherapy, yes, they can do gentle slopes, but before that, first keep on walking on the level ground, because this helps to keep up the muscle strength, right? So, and the other thing is, this exercise not just includes the physical exercise that the patients do at home, this also includes physiotherapy. This is the number one thing that you need to take home from today, because physiotherapists can help quite a lot in the management of knee osteoarthritis. So if you do one thing, the moment that you diagnose as knee osteoarthritis, try to refer them to a physiotherapy unit. The closest hospital, almost all base hospitals have a physiotherapy unit. If not, like, tell them if you can afford in the private sector, go to physiotherapy, because you don't have to go every day. They will see you once a week or once every 2 weeks, sometimes even once a month, depending on the severity. And then they'll teach you exercises. What you need to do is stay home, do the exercises that they teach you. And when I mention the word exercises, the old archies are like, "I don't exercise." When I tell them you don't have to put on a short and running shoes and start running, these are exercises that you're going to sit down at home and do by yourself. You don't need anybody's help to do these exercises. When you explain it that way, they are okay. And the other thing I tell them is, if you do the exercises now, you would be able to avoid undergoing a knee replacement, because knee replacement is the only ultimate treatment for the osteoarthritis. You tell them, they will go home and do exercises, because nobody wants to undergo knee replacement in our country. I don't know for what reason. The reason everybody gives is he couldn't walk after the surgery. And I asked, okay, who is the surgeon who did the surgery? I'm going to send all my enemies to that surgeon, because it can't happen. But they find some or the other patient, somebody's experiencing, they did the surgery, they had the surgery, they couldn't walk, so I don't want the surgery. Because at one point, surgery is the only option. So if you explain to them well enough, most of them will agree. But if you want to really make them do physiotherapy, tell them, if you don't do this, within the next 2 years, you are going to need 2 new knees. So you better do it now, and they will do it. So physiotherapy, what do we do by physiotherapy? So it's all about joint offloading, because what can we do? So if you have a tree that is going to fall down, it's like going south, going to fall. What do? You will go and give it an external support to keep it upright. So that is something similar to like what we are doing with physiotherapy, because what we try to do is get the core body to strengthen up. So I will show you a few photos and then you will realize what I'm talking about. Weight reduction. So weight reduction is very important, but extremely difficult to do, particularly when the patients have bilateral advanced osteoarthritis, because diet definitely helps. And somebody tells you diet can't help. Professor Langasekar used to tell us, have you seen fat people in Ethiopia or Somalia? Not really. So if you don't eat, you don't get fat. So yes, so diet can take you a long way. But the thing is, when they are old, these organized fat, it needs exercise also. And this is a patient who can't walk because of knee pain. So it's kind of a vicious cycle. The weight makes the osteoarthritis worse, and the osteoarthritis helps the patient put on weight. So you need to break it somewhere. So challenging, but can do. But what the research says is, if you want to like see a significant reduction in the pain levels, you should achieve a minimum of 5% reduction in the body weight, which is quite a lot for a patient who is struggling with weight. When you say 5%, quite a lot. But when you put it to numbers and tell a 70 kilo patient, okay, you need to lose only about 3 kilos and you will feel a significant difference, then they'll be happy. Okay, 3 kilos is not undoable. So they try to. Okay, so remember that you are not asking the patient to go to the normal BMI. It's unrealistic for most of the patients. What you're asking them to do is a 5% weight reduction. Okay, so translate that to numbers and tell them. And then Tai Chi. Tai Chi is very helpful. The only thing is, in Sri Lanka, Tai Chi trainers, you can look for Zumba trainers, you can look for aerobics, but not really Tai Chi. So given that our Chinese population is going up, probably now we can look for help. Tai Chi is actually a very good exercise. The reason is, in Tai Chi, they like what they do is it's very slow movements, or not like Zumba where the movements are very rapid. I hope you all have seen Zumba. So it's very rapid, energetic movements, so good for weight reduction. But in Tai Chi, what they do is very regulated, slow movements. To do this is very difficult. You can like look up a Tai Chi video on YouTube and try doing it, because slow movements are much more difficult than you think, because it's need a lot of coordination and core body strength. So that is what they do in Tai Chi. And the other thing, patients find it easier to tolerate because it's not a lot of vigorous physical exercise. Very slow movements, and it does a lot to improve the core body strength. And walking it with a cane in the sense just with a stick in our setting, and oral and topical NSAIDs, and intra-articular steroids. So these are the evidence-based management steps. So these come from the 2019 American College of Rheumatology Guideline for Management of Osteoarthritis. So all these are evidence-based. But one more, knee guards, should you or should you not? I would much rather you tell them to stay off of knee guards, because what you are trying to achieve with physiotherapy is counteracted by giving them knee guards. Knee guards are okay for a maximum of 1 week if they get a pain flare. So when they have a severe pain, I told you just like in inflammatory arthritis, they can have flares and remission of the knee pain. So if they are having a pain flare like that, tell them, okay, you can use this for 1 week, but 1 week you are going to take this off. Because the thing is, your muscles have memory. If you go back to your pathology years, skeletal muscle has memory. So the more weight it bears, it hypertrophies, because the muscle knows it needs more fibers to act. So it will hypertrophy and it will regenerate. This is how the bodybuilders put on their muscle mass, by doing the weights exercises, because the more they use, the muscle hypertrophies. The same goes the other way as well. The less you use, it atrophies. So this is atrophy. Once we had a batchmate who had a bike accident, and he had a plaster cast, back slab actually. It was not a full cast back slab. Immobilized for 2 weeks because of a ligamental injury. Just 2 weeks later, we accompanied him to physiotherapy. He could not even lift a 500-gram sandbag with the leg. So that is the amount of disuse atrophy that you're looking at in bulky muscles. Because the bigger the muscle, the more the disuse atrophy is going to be without use. So when the knee guard is there, your muscle thinks, okay, the guard is there, so why should I bother? Because keeping the muscle mass is a lot of hard work. So why should I bother if somebody else is doing the work? So that leads to disuse and atrophy. So somebody who has been wearing a knee guard for a long time, when they come and lie down on the bed for the examination, I tell them, take the knee guard out of your bag. I don't even ask them, do you wear a knee guard? I tell them, take the knee guard out and show me. Because I know they are wearing. Just by looking at the quadriceps strength, we would know. Right, and these are the, I know you can't read this, don't worry, I'll just say from the top, because I found it very difficult to get this onto a slide. So these are the interventions they have said against. Like the ones in deep breath, they are strongly recommended against. And the ones in the sort of the pinkish one, that is conditionally against. Not recommended. Conditionally against and strongly against. So if you see the strongly against, top to bottom. So the bisphosphonates, so this is for hand, knee and hip. So all across all the types of arthritis. Bisphosphonates. Some people unfortunately treat osteoarthritis with bisphosphonates. Don't. There is no evidence. You are only adding harm. And then the other thing is glucosamine. There is no evidence. Glucosamine has strong placebo effects. So there have been glucosamine as well as chondroitin. Now when you come down, chondroitin has conditionally against hand osteoarthritis, because for chondroitin there is no trials to go for hand osteoarthritis. That is the reason why. But for hip and knee OA, they say no, don't give. The reason is there are a lot of trials that are available now. If you go and search the internet, if you go and do a PubMed search for glucosamine and chondroitin evidence, what is the evidence? You will come across a lot of conflicting evidence. Some say give, some say don't give, some say there is an effect, some say there is no effect. So you are kind of lost, okay, what should we believe? But the problem there is why the ACR has strongly recommended against the use is a lot of studies that have proven benefit in the use of chondroitin and glucosamine are actually industry-sponsored studies. So there is a lot of publication bias, publication and reporting bias. So, and the biggest study, it's called GATE, GAIT, was a big randomized controls trial, huge one, recruiting more than 400 participants. So that was a very strong study which showed it was similar as placebo. There was no improvement at all. And the other very interesting was, so they gave glucosamine chondroitin combination, I think, in 1 hour. Another arm was given placebo, so it was like similar in appearance, but it had no medicinal value at all. And the third group was an NSAID, if I remember correct. And they compared the 3 arms. And all 3 arms, at the end of the follow-up period, there was a 20% improvement in the pain. So whether you give placebo, whether you give an NSAID, or whether you give glucosamine, there is a 20% improvement in the pain. So how does this happen is the problem. So this is why pain is a very complex phenomenon. Pain has a lot of psychomotor inputs. It has a lot of like perception and then placebo and the psychologically motivated things. So this is what is being addressed by placebo. But they again say in the, like if you read through the paragraphs here, the in between lines they say, however, if the patient says that they want to use a glucosamine or chondroitin preparation, we can't really discourage them against it because there is a strong placebo effect that is associated with it. And what we have seen in clinical practice, there is pain relief effect and there's no harm. That is the reason why they are saying it. So there is no harm that is associated. So given there is no harm, strong placebo effect and in some instances a pain relief effect, particularly with high dose of chondroitin, high dose of glucosamine, there is a pain relief effect. So given that, there is no harm. So if the patient says, I really want to use this, there is no harm. This is why in other countries, chondroitin and glucosamine preparations are not prescription drugs. These are dietary supplements. Anybody can buy them off of a shelf of a supermarket. They don't need prescriptions. Okay, so that is that. And then things like MTX, hydroxychloroquine, they have no evidence whatsoever to be given in osteoarthritis. And then the other important thing, PRP, because it's gained a lot of popularity in the recent years. PRP and the intraarticular hyaluronic acid injections. I told you intraarticular steroid injections are evidence-based. They are strongly recommended in hip as well as in knee osteoarthritis. There is no recommendation in hand osteoarthritis. But with regard to the PRP and the hyaluronic acid, if you go through this, they say strongly recommended against. They don't recommend it. So again, if you take the PRP, there are very conflicting results coming from different trial studies. The early trials showed promising results, so that's why it went into the randomized controlled trial stage. When it went to that stage, because you know, out of all the clinical studies, RCTs have the highest strength of evidence. When it went to that level, compared to normal saline, there was no benefit. Okay, so the strongest available studies show compared to normal saline, there's no benefit. And the other biggest problem is the cost. The cost. So in a healthcare setting like ours, can we really bear the cost? So I don't practice PRP. I have nothing against those who do practice PRP. Just go ahead and do it. But then we have to think twice, because if the steroid injections give the same benefit, why should we use something that is about like 300 times more costly than that? Because if you take a steroid injection, just for the injection if we see and the instruments that I know, it takes only about 1,000 rupees. But for a PRP injection, the hospital has to bear a cost of nearly 25 to 30,000 rupees for the preparation of the plasma and everything. So is it really worth it? Because the thing is, PRP, like the one reason why it hasn't come to the guidelines is because there's no agreement. How much should you give? How frequent should you give? So some studies are given every 3 weeks, some have given every 1 month. And most of the centers I know currently use every 3 months. So every 3 months you can have an injection and stay pain-free. Whereas if you give a steroid injection, again the pain relief is going to be there for 3 months. But after 3 months, the pain is not going to come back to the same level if the patient is undergoing physiotherapy. So what will happen if you give only one PRP injection? Is it the similar to the steroid injection? Maybe. If they had just one PRP injection and had physiotherapy, one steroid injection and had physiotherapy, if the outcome is the same, why are we spending an unnecessary amount of money to give PRP? And the other thing, it's a blood and blood product, so the risk of infection and reactions, painkillers, everything is more compared to steroid injection. Okay, so this is the reason why I don't personally practice and the international consensus guidelines agree. Right. Next slide. Yeah. So what is the basis of all these evidence-based treatments? So I told you that in physiotherapy, what we try to achieve is to reduce the mechanical loading of the joint and to improve the external support to the joint without a device. I say without a device because we try to do this without the help of braces or knee guards. And pain relief with medications that are effective. So you would have seen what is the evidence-based pain relief. It's NSAIDs. NSAIDs are the only evidence-based pain relief. They say like tramadol and duloxetine, they say with like conditional approval only. If nothing else is working, okay, you can try, but nothing stronger than that. These things like these neuromodulators such as gabapentin, pregabalin, they have no place in the management of osteoarthritis because knee OA pain does not respond. Not even paracetamol, actually speaking. Paracetamol is not evidence-based. And the other thing, when you prescribe paracetamol to take SOS to elderly, it is with risk. Because when you tell them take it SOS and if they are in pain all day, there is a high risk of overdose. So this is one of the things that is highlighted in the guidelines. Try to avoid giving acetaminophen, paracetamol, SOS. So this is what I told you about quadriceps wasting. So if you look carefully, you will see compared to the right knee of this patient, in the left knee, the quadriceps bulk is much less. So this happens with disuse because then you don't have to wear a knee guard for this to happen. Because imagine the last time that you had a knee pain, when you try to walk, how do you tend to walk? You tend to bear weight more on the unaffected side, less on the affected side. So you walk with a limp because you try not to bear on the painful leg. That's a natural response. Whenever you have a pain, you don't want to aggravate that. So that itself is enough for the quadriceps wasting because you are not using that compared to the other side. So that happens quite a lot. And the next one, we have all gone through this stage, learning to walk. So once you have knee osteoarthritis, that is also like this. So why do the children take a long time to go from walking on flat ground to walking steps? Because we know like by the time they are about 9 months to 12 months of age, most of them start walking, holding on to things. By about 1.5 years, they are able to walk independently on level ground. But it takes up to 3 to 5 years for them to do stairs. Why is that? Because doing stairs is not easy. It's a lot of coordination. Doing stairs needs a lot of coordination and development of the core body, alteration of the center of gravity. Everything has to come together for somebody to be able to climb stairs. So patients in knee pain, knee osteoarthritis coming and telling you I can't climb stairs, you have to tell them don't be surprised because climbing up and down stairs is a lot of hard work. So you can be retrained, but it takes a lot. I want you to have a look at this image. So this lady, so she's obviously exercising, a fitness freak, but going up the stairs, trying to going up the stairs, and can you see like what are the possible muscle groups that are involved? Because when walking, when we think about the knee, we only think about quadriceps. Is it all about quadriceps? So is there something else other than the quadriceps? Because remember, we are bipedal creatures. We were not supposed to be, but at one point in the evolution, we decided we are going to go on 2 feet, not in 4 feet. So it's very difficult. Maintaining the bipedal posture is very difficult because we are going against gravity. The full body being held against gravity just with the support of the skeleton. So it's very difficult. And on top of that, we are now talking about climbing stairs. So it's not just your quadriceps, it's not just your knee joint. So I actually realized how weak our population's core body strength was during the petrol crisis. So I was waiting to get onto a bus, waiting, and buses were coming and going. They were extremely crowded, and then there was this one bus, there was a little bit of space on the footboard. So there was about 60, maybe about 55 to 60-year-old female in front of me. So she was trying to get on the bus, and I was waiting for the moment her arm would come out of the socket. Because getting on the bus is like hanging onto the bus and then lifting yourself up. This is our core body strength. Because that tells you, like, to get onto a step, you don't just use your knee. You don't just use your quadriceps. You need your gluteus, you need your abdominal muscles, you need your back muscles. So all of this propel you upwards. So the lifestyle that we are leading has led us to have so poor core body strength that trying to get onto a bus, that big step, needs all of us to push. And I had to go and like give her a little push to get up onto the step, otherwise she would have lost her arms trying to get up. Okay, so I'm not surprised that our patients have this much of knee osteoarthritis, because the rest of the body is not bearing any weight, because the core is so weak. And when you try to when I try to sometimes get them to do certain exercises on the lying down position, I tell them, okay, tell me what the physiotherapist showed you. And they find it so difficult to just lift one leg off of the bed, straight leg. Just a straight leg raise on one side, they find it very difficult to do, because again, what is doing your straight leg raise? It's not just the quadriceps, it's your abdominals. So abdominal muscles are that weak, that's why we all have paunchy abdomens, pouting out. So now this is what I wanted to show you. So if you want to do stairs, if your patient has difficulty in climbing stairs, instruct the physiotherapist, get them to do core body strengthening, and then this problem will be sorted. So the bottom line is, utilize the services of physiotherapists. Okay, they can do an amazing job, but depends. I'm not telling everybody, but majority of them can do an amazing job. Also tell the patients that they think when they go for physiotherapy, like they do this IR and ultrasound therapy and everything, so the patients are very happy, they did something and then that's it. And they go for the next physiotherapy session 2 weeks later, and then 3 months later they come and tell you, but it's the same place. And I tell them, it's very temporary, because what you are trying to achieve by all these physical therapies, these are not physiotherapies, these are physical therapies. You can achieve the same by using a warm towel and fomenting the area. That's it. By we are using IR and ultrasound therapies, it is more targeted. We can reach the level of the tissue, the depth that we need to, but it's not much different to what you would do by using a warm fomentation. But there is a reason why the therapists do this before they start the patient on physiotherapy. That's because doing this helps to relax the tissues. It helps to relax the tissues, the pain is less, and the patient can be engaged more effectively in the therapy. But that doesn't mean it can use to replace the physiotherapy. No. What the patient has to do is, okay, do whatever that during the session, learn the home physiotherapy program and go home and do it at home. So as long as they don't do it, yes, of course, it's going to be static. It's not going to improve. Right, and last but not least, the surgical treatment. So when it comes to that, so unfortunately, as I told you, among our population, there is poor acceptability. However, like what I tell them is, okay, do 6 months of physiotherapy, 6 months of good physiotherapy. If you are not improving, if you cannot still do your activities of daily living without pain, why suffer? Because you do a TKR, within 48 hours you will be walking. Right? So they don't have to suffer. But remember, the patient should be chosen with care and prepared with care. Remember I said, the patients have to have had physiotherapy for at least 6 months before the decision for a surgical treatment is taken. Because whether a patient should have surgery or not should not depend on how bad the X-ray is. It's not based on that. So the surgeons decide to go for a TKR if the pain is so bad that they can't do activities of daily living. It's very well evident that X-rays and clinical features don't go hand in hand all the time. Sometimes we see horrible X-rays, like the knees are completely this varus deformity, everything is there, but they are okay, like they can manage their activities of daily living without being dependent. So as long as that, you don't have to go and chop the knee off and put in a new one. But the other way around is also true. The knee X-ray might not show much, but the patients may be in excruciating pain. No matter what you do, they have pain. Particularly those who have meniscal injuries, cruciate injuries, those who have like football players and all that. Once you have all these ligamental injuries, the knee is unstable and the pain is pretty bad. So no matter how much of physiotherapy that you do, there's so much that you can go, so far that you can go. So beyond that, it has to be with the TKR. So this is what I told you. Indication is not a bad knee X-ray, but the limitation of activities of daily living. And in certain countries, actually, this is a must. Before they are able to be referred to an orthopedic surgeon, they have to have completed evidence of completion of at least 6 months of physiotherapy. Because this helps in 2 ways. For one thing, if they have undergone correct physiotherapy, a significant proportion of patients are not going to need surgery. That is one reason. Second reason is if they have had physiotherapy, muscle strengthening, so their core is stronger, you do the knee surgery, these are the patients with the most successful outcomes. Post-surgical mobilization is very easy. If you have done physiotherapy, do the surgery, and then after surgery physiotherapy, mobilization is very easy. And with hip OA, this is a bit different. With hip osteoarthritis, physiotherapy cannot go so far. So as long as the other patient factors are agreeable, going for an early surgery is the better option there. But is there a middle path? Can we go for something that is not surgery, like neither surgery nor physiotherapy, like something in between? There is one option that is coming up now. It's called genital artery embolization, GAE. But there is a growing body of evidence, but definitely this cannot replace surgery. But where this can be applicable is for those patients who are really not willing for surgery, who have mild to moderate osteoarthritis, who are not really responding to physiotherapy. Because what we are trying to achieve here is a long-term pain reduction. So we go and selectively select the artery that is supplying the knee joint. And there are highly vascular areas, because when you have damage, I told you there's inflammation and hypervascularity, and select those selective branches and then embolize that. This achieves pain reduction, but still it's very preliminary level. And in Sri Lanka, it's under investigation, so we have just started doing a big study on this one. And even if it is available, like, the expertise is not widely available. So that's the problem, because this needs interventional radiologists who are experienced in doing this. Right, so the last message that I want to give you is that knee pain is not always osteoarthritis. Right, so just because an obese middle-aged female comes with knee pain, don't assume that it is osteoarthritis. One thing that I find useful is, when a patient comes and tells me knee pain, I start thinking that this is an inflammatory arthritis. So that is my starting working diagnosis, is inflammatory arthritis. And then I look, is there anything to support that assumption? If not, okay, then it is osteoarthritis. Because missing an osteoarthritis is not going to do much harm. Missing an inflammatory arthritis, you are doing a lot of harm. The reason is, inflammatory arthritis, you know, if untreated, leads to secondary osteoarthritis. This is not as simple as the primary OA of the knee that you see, because secondary knee OA is secondary to inflammatory arthritis. It is very rapidly and floridly progressive, and it is very damaging to the knee. They need like knee replacements at the age of about like 40, 45. They need knee replacement, which is very sad, because when a replaced knee can last for so long, because they also come with an expiry date. A replaced joint can function only about 12 years after replacement. So imagine a patient having a knee replacement at 40. At 52, they need a knee revision, which is horrible surgery in the knee. Right. So inflammatory arthritis of the knee is commoner than you think. And the worst thing is, most of these inflammatory arthritis that happen in the knee, the hip, and the lower extremity, these are spondyloarthritis. This is not rheumatoid. They are spondyloarthritis. Why I tell you that that is the worst thing is because 50% of patients with spondyloarthritis don't have elevated ESR or CRP. So the diagnosis is purely clinical, because you know that spondyloarthritis don't have a positive rheumatoid factor, so there is no serological marker. ESR, CRP you do, it comes back negative. So then how do you diagnose? So if they get missed, very frequently they get missed, right? So this is what I told you. So how do you diagnose? As I told you, go back to the history. Is there significant early morning stiffness? Significant early morning stiffness, and the patient feels better walking on a bum knee, that's not osteoarthritis, right? Right, so a good history and a thorough examination, that is how you are going to diagnose, and this is the problem I told you with inflammatory markers and rheumatoid factor, because the majority of cases of knee inflammatory arthritis are spondyloarthritis who will have a negative rheumatoid factor and normal inflammatory markers. Right, so this is like a take-home message. So suspect inflammatory arthritis and refer if you see any of these. Young age of onset. If the age of onset is less than 40 years of age, don't assume it is osteoarthritis. Just because the patient may be obese, don't assume. I recently came across a patient who was like I diagnosed as having an inflammatory arthritis, and I asked her, do you have any family history of inflammatory arthritis? Because she's RF negative, rheumatoid factor negative, enthesetic type, so the spondyloarthritis type inflammatory arthritis. And in the family history, she told me, my sister has had bilateral hip joint replacement. I asked why. She said for osteoarthritis. Then the patient herself was only 43. So I asked how old was the sister by the time they replaced both hip joints for osteoarthritis, and she said she was only 35, which tells me that was not an osteoarthritis. That was secondary to an inflammatory arthritis, because this type of spondyloarthritis type, they have a very strong family history, not like rheumatoid. So luckily the patient is now abroad, and I asked her, is she on treatment? She said yes, she's now on treatment. So onset less than 40 years of age, be careful. And the other thing is unilateral knee involvement. The other knee, perfectly fine, no symptoms at all, only one knee. So like, why would just one knee get told? So I told you, like, whatever said and done, these are degenerative conditions. Even though there is an inflammatory component in the pathogenesis, blah, 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 these are degenerative conditions to start with. So if there is unilateral knee pain, the other knee is perfectly fine, think this can be inflammatory arthritis. Then the next one, days with pain that are interspersed with days that are completely pain-free. Only 2 days ago I saw a patient like this in the clinic. So completely pain-free period. So someone was a potta pain, but like there are other days where she can barely walk because of the pain. Osteoarthritis doesn't really behave like that, because in OA there is always like a background pain that is always there. And on top of the background pain, yes, you may get spikes, but you don't have completely pain-free periods. So actually that patient investigated, I started investigating because the rest of the examination, the patient didn't complain. But looking at the fingers, she had about 2 swollen PIP joints. So that was not an inflammatory, not an osteoarthritis. Other one is valgus deformity. Can you remember what is a valgus? So we call a joint to have a valgus deformity if the part of the limb that is distal to the joint is moving away from the midline. So the valgus deformity of the knees would look something like this. So varus is like this, moving towards the joint, towards the midline. Valgus is going like this. So in the knee osteoarthritis, your medial knee compartment, medial tibiofemoral compartment gets more affected compared to the lateral tibiofemoral compartment. Because of this, what the primary osteoarthritis would lead to will be a varus deformity. That's why they have bow legs, like it's bowing out like this. That's what you would usually see. But instead of that, if you see a valgus deformity going outwards like this, be careful, because valgus deformities affecting the lateral tibiofemoral compartment more are usually inflammatory in origin. There may be a secondary osteoarthritis, however, the primary inciting event is usually an inflammatory arthritis. So if you see knee pain with a valgus deformity, my advice always refer if you're not sure. Then significant early morning stiffness, which I told you, and other joint involvement. It's not just the knee, but knee and the ankle, knee and the hip, and sometimes upper limb joints. So it's not osteoarthritis. And the patient tells you that he or she feels better when they are walking on the affected knee. So this is exact story that a 34-year-old female told me. So she was about this big, huge lady. BMI was actually at 42. I had to refer her to the dietitian also to get the weight down. But BMI 42, so she always complained of knee pain, and her house was 3 stories, the usual candy story. So 3-story house, so she does the climbing up and down every day. And she has 3 kids, so always on her feet. But unilateral knee pain. So an examination is also extremely difficult, because when they are very obese, the knee examination difficult to detect synovitis. But on examination, I thought that there was synovitis despite all the obesity and everything. And then I asked her about morning sickness. She would say the usual story of our patients. You asked early morning worsening, no, but then I asked her, kept on asking, and then she told me, in the morning, she would feel as long as she's walking. She feels better as long as she's walking. If she's seated, she can't get up. In the morning, she can't get up, but she's happy to walk. Somebody with an osteoarthritis of the knee will not be happy to walk. Take it from me, they are not happy to walk. They would rather rest. So somebody saying this, be careful. Right. So this is the last one to say the key points. So knee pain is not always due to osteoarthritis, and the easy way to start is assume all knee pains are inflammatory in origin and then try to rule out osteoarthritis. That is the easier way. And if there is a suspicion of inflammatory arthritis, please refer early, because inflammatory arthritis leads to very rapidly progressive destructive secondary OA, which is very difficult to manage later on. And in osteoarthritis, choose the medication for pain relief wisely. Try to minimize the use of medication for pain relief, for one thing, because this is going to be a chronic condition. And remember, the patient population whom we are treating are going to have a lot of comorbidities. And elderly people above the age of 70 years, I am very careful when I prescribe NSAIDs, because peptic ulceration and then renal failure, the cardiac toxicity, you name it, they have it. So early introduction of physiotherapy and the correct advice on physical activity will take you a long way. You don't need a lot of medications to manage osteoarthritis properly. And in end-stage disease, the treatment is surgical. Whether they like it or not, the treatment is surgical. But make sure that you prepare the patient well. Prepare the patient well in the sense, have adequate sessions of physiotherapy, adequate duration of physiotherapy before they are referred to the surgeons. This is what I wanted to say. So if you have any questions, I will be happy to answer. Thank you very much. And one more thing that I forgot to mention earlier about intraarticular steroid injections. So patients take steroid injections for granted, because once the steroid is given, they are like very happy, the pain gone, nothing there. But what is after that is what is usually missing. Because I know that a lot of people give steroid injections, but what should you do after that? 2 weeks after the steroid injection, they need to start physiotherapy. You need to tell them that the steroid injection will work only maximum 4 months, usually about 3 months. 3 to 4 months, that is it. So after that, you are going to be back to square one if you don't start on physiotherapy. So the treatment has to start at least 2 weeks after the steroid injection. So that's a must. Yes, that's a good question. So calcium and vitamin D both have been investigated in the knee osteoarthritis, not just knee, hip and hand osteoarthritis all through. So none of these medications have shown any benefit, because there was one study done on vitamin D which showed early promise, like there were a reduction in the pain scores, but then it failed to hold up in the subsequent studies. So what they say is probably it is having, because our patients have a lot of musculoskeletal pains because of vitamin D deficiency. So probably when you replace the vitamin D, they have improvement of the general MSK health rather than the knee itself. So one of these studies actually looked at knee MRIs also serially. Was there any change in the MRI findings? Nothing. So at the moment, for just the management of osteoarthritis, calcium and vitamin D has no place. No place. Again the same. That's why I told you bisphosphonates are strongly recommended against. Because bisphosphonates should be used in the treatment of osteoporosis, true. And there are like few cases that we come across sometimes, severe knee pain, refractory to whatever we do. And the other thing, on examination there are minimum signs but excruciating severe pains. And in 2 such patients, I had the ability to get an MRI later on, only to see they actually had tibial plateau fractures that are like, you can't see them on X-ray. X-ray is going to be normal, and like they were tibial plateau fractures, and then doing the DEXA scan, they were found to have actually osteoporosis. So osteoporosis is stress fractures on the tibial plateau, that's why severe excruciating pain. So such patients, yes, you have to start them on a bisphosphonate, not for the knee pain, but for osteoporosis in general. And the knee pain will also respond, might respond to a certain extent. But other than that, just for the management of osteoarthritis, there is no place for bisphosphonates. Because what bisphosphonates do is they go and inhibit the osteoclast activity, which has nothing to do with the pathogenesis of OA. Yes, I might be having a cutthroat at the end of the day, I know that. But like, yeah.
The thing is, you mentioned there's some help in, it's helpful in pain relief.
Yes.
Are we supposed to do
That is a good question actually. So I also use these products. One of the reasons I use is, yes, it does have a placebo effect because our patients are not happy unless you give them a tablet. They want a tablet. And as I said, there's no harm giving, and it has a placebo effect, plus like at high doses, like 1500 milligrams a day doses, it has some pain relief effect. So that is there. So rather than giving them an NSAID to take every day, I much prefer this. So I don't prescribe long courses of NSAIDs, but rather than that, I would prefer prescribing a higher dose of a chondroitin or a glucosamine sulfate. But you have to explain to the patient what it does. That I do. I explain to them, this is not going to grow your cartilage back. The pack may say so, but it's not going to happen. What it does is, it's going to keep the symptoms at bay. You need to do the exercises, without which it's going to go back to what it was the moment that you stop the tablets. So as long as you explain to them what it is, they are free to take. So this is what all the international guidelines say. They say like, even though we say that it's not going to help, patients are like, they are geared for taking these. So, and as I said, these don't need prescriptions in other countries. So in Sri Lanka only, these are prescription drugs. So if they want to buy it off of a supermarket shelf, they'll be like, yes, take it. But like how low, how far it is going to take, the patient needs to know the evidence. So tell them the evidence and prescribe. But if you are going to achieve a significant pain relief, yes, you need to go at high doses. That's what the studies have shown. So at least 1500 milligrams a day. And there are no side effects. It's not going to affect your kidneys, your liver, nothing like that.
What are the exercises which you prescribe to patients?
Yeah, so that is again a good question. So exercises in the sense, what I usually prescribe is, as I said, walking on the flat ground. But beyond that, what exercises from a physiotherapy point of view is needed by the patient, I generally use the therapist decide. Because the thing is, physiotherapy is like our own drug prescriptions. It is a prescription. So the prescription should be customized. You cannot generalize the same set of exercises for every patient. The patient should be able to perform the exercises to begin. And the other thing, what is the frequency? For how long should you do? Where should you start? Should you start with resistance training? Should you start without resistance? They all depend on the patient's baseline ability. This is something that I don't have the time in my clinic time to assess, because it takes a lot of time per one patient. If somebody does a proper physiotherapy assessment, the initial assessment takes a minimum of 15 minutes. Again, time that I don't have. So what I tell them is, okay, go meet a physiotherapist, they will tell you what to do. But in the meantime, as exercises what you can do, walk on flat ground, and if somebody is a swimmer, so this is where we come into problems, because most of our patients are housewives, elderly, they can't swim. So if you come across male patients who are swimmers, tell them take up swimming, because swimming is a very good exercise. It's non-weight bearing. Without bearing the weight, it strengthens the muscle. Because it's not bearing weight, the pain is less, they can tolerate it better. And because it's resistance, because you try underwater walking, that needs a lot, has a lot of resistance. Sort of a resistance exercise, so it builds up the muscle bulk. So it has everything. So we use this in physiotherapy as well. We call this aquatherapy or hydrotherapy. So hydrotherapy is based on this principle. Because of the upthrust, you don't feel the weight. So it's non-weight bearing, but strengthening. So this is the advice that I would give. And as for the exact physiotherapy, now when I write to the physiotherapist, what I tell them is, start with the quadricep strengthening and then move on to core body strengthening. So core body strengthening includes your abdominals, gluteus and the erector spine, everything. So in the absence of further questions, I think we can wind up. Everybody should be hungry now. Thank you very much.